Hi, everyone. Thank you so much for joining us. We're really excited to share with you some groundbreaking evidence associated to the new Viz Aneurysm product. Joined with me tonight, we have Dr. Sunil Sheth, who's the Director of Vascular and Interventional Neurology at UT Health. And we also have Christopher Willey, who is our Director of Product for Neurovascular. We're excited to give you an overview of Viz, aneurysm and subdural, as well as dive into the data that was released at SPIN and some of the upcoming data that we have coming out. So I'm going to turn it over to Chris to get us started.
Awesome. Thank you, everybody. Nice to meet you. As Jamie said, I'm a director of product on the neuro side. So my team and I are responsible for building products for the hemorrhagic and ischemic side. And I'll talk about Viz aneurysm briefly, and then also talk on subdural hematoma, both of which are really new products for us. The next slide. So aneurysm has been really fun to build. When you think about what put Viz on the map, it's really the acute workflow. You have LVO, where we detect disease, where we know that time to treatment is important. So it makes very good sense that if you can detect an LVO on the phone, show it to providers, let them activate workflow, you're going to improve patient care. Really fun, easy products to build, made huge impacts in the space, and they're continuing to benefiting patients. Aneurysm is very different because it's our first foray into what we would call non-acute. And what I mean is when you detect an aneurysm, you might follow it for 1 or 2 years. You may never do anything. You might treat it, but it certainly doesn't have the acuity that LVO does. So we spent a lot of time, my team and I, speaking to physicians, nurses, providers, and trying to figure out what product could we build that would be of most value to all the hospital systems. And at first it was thought maybe we would help find incidental aneurysms, in that we know aneurysms are missed. There's about, if you read the literature, 14–25%, something around there, aneurysms are missed on your typical rad read. However, it's very inconsistent. If you go to the big university centers that are flush with neuroradiologists, the rate is lower. If you go into hub and spokes or people who outsource, it's a little bit higher. And when we did the research and thought about it and started talking to more physicians, it was very sporadic that finding missed aneurysms would be the main value of the product. But one thing did stand out, and universally everyone said, when I see patients with aneurysms, for the most part, they were found, they just weren't referred to me, and it took a really long time. So we call that patient leakage. And the problem we aimed to solve was simply that patients with aneurysms get lost. And the typical scenario is ENT or a different specialist orders a study for jaw pain, ear pain, eye pain, whatever. And buried in that RAD report would be 4mm MCA aneurysm found. The referring physician sees it, but they don't refer it to a neurosurgeon or a neurologist quickly enough. So it sits on their desk. And those patients tend to get lost. They may even leave the system entirely. Next slide. So with that in mind, we built the product for aneurysms to certainly help be a second set of eyes to help find missed aneurysms for their radiologists. But for the most part, we wanted to improve that referral pathway. The basics nuts and bolts of the product, we auto detect saccular aneurysms 4mm and bigger. So we typically are installed to read all head CTAs. We will find the aneurysm that's 4mm or bigger, has to be unruptured saccular. This will be populated into a list on the physician's phone or a desktop, allows the physicians to read the study as they would in a PACS machine, just maybe a little faster because it's sent to their phone. They can grab it anywhere in the cafeteria at home and take a look. If this is something of interest, they can share it to clinic. Now, when we say clinic, read that as distribution list. That can be anything the physician decides to make it. They can send it to other physicians. They can send it to their own clinic. They can send it to their nurses, PAs, et cetera. The idea is that this patient for whom an aneurysm was discovered will be seen by a specialist more quickly based off our discovery with the AI algorithm. Next slide. So that's what it does. And how does it do it? Well, basically, as I mentioned before, we generate an aneurysm suspected list. And you can see this here on the first phone icon. You scroll through it. If it's of interest, you simply hit the aneurysm clinic refer tab, much like sharing a text with your family. When it's shared, you can mark as done. We do this because we found that it's very clear. It's very often that you send a patient, you forget, did you send it or did you not send it? So we allow that patient to be cleared from the list. So once it's off your phone, it's in your clinic distribution list to be managed on your own internal workflow. We have back-to-backs capability and aneurysm on web desktop as well. We also learned that very often when you send a clinic, whatever group of providers or health and nurses, PAs, et cetera, are in that clinic, they're typically operating on a desktop. So we built that capability in as well to manage that patient list. So that is a very quick, high-level view of the aneurysm product. We're installing it now. Please try to get a closer look. We certainly have enough people to come visit you and show you on your phone, but this is exactly a high-level look at what it looks like and the problems we're trying to solve for you. So I think the next one might be subdural. Subdural is probably the most exciting thing to happen in the neuro space in years, and we just have approval. We'll be launching a product to participate in this space. Go ahead. And the idea behind this really is tailoring on the MMA procedure and the interest in subdural hematoma. For years, we all know these patients have been suffering. There's been no great solution to treat them, but with the MMA procedure, we're finding that these patients are having a great option for significant success, significant great outcomes. So we thought, how could we help bring care again in a non-acute world to these patients more quickly? So we built an algorithm that detects any subdural hematoma. It'll be acute or be chronic. It's really for the physician to decide. So very similar as to aneurysm workflow. Again, it's non-acute. So what we do is we populate a subdural hematoma suspected list. We let the physician take a look at it and again, share it to clinic. So you can go on. And why we think this is so exciting is with all the trials going on, and we know the cost of burden to treat chronic subdural, we think this will make the biggest impact across so many different areas in healthcare. First and foremost, you have the patient, right? You make sure these patients who have been suffering with chronic subdurals are found. There is an apathy towards these patients because there's not been a great solution. Now we know MMA is proving to be pretty effective. So if we can find them early and send them to the specialist, that's great. We know this is the most common neurosurgery diagnosis there is. It's increasing mostly because of population. We're all getting older. The prevalence becomes higher. And they're very, very expensive to treat, typically managed with burr holes, et cetera. That generates a pretty significant post-acute cost care. And obviously you can see the payer impact. We're in the early stages of this treatment. All signs are pointing that it's going to be pretty impressive and I think groundbreaking from how the MMA procedure is able to help patients. And with this first version of the product and new versions to come, we're incredibly excited to be participating in it. So that is a very, very quick view of two of our latest products. I appreciate it. So I'll be handing over right now to do what you're all here for. So take it over, Dr. Sheth.
Well, great. Thanks, Chris, for the introduction and overview of the product. And thank you to all of Viz for the support in doing this study. I have to give a special shout out to Christopher Love, who's on the call, really helped us a ton in getting this study together. Couldn't have done it without him. So I'm Sunil Sheth. I'm the director for the Vascular and Interventional Neurology Division at UT Health here in Houston, Texas. We had the opportunity to do this study to evaluate the Viz Aneurysm software. And we wanted to look at not just the performance of the algorithm, because I think that's something that's important, but can be done in a relatively straightforward fashion, but ask the next level question, which is, how does that impact patient care? And how does it impact clinician ability to deliver patient care? So we took about 1,200 CT angiogram scans, and these were done in patients at 8 of our hospitals across the Houston area. And just to give you a sense of those centers, there's 1 comprehensive stroke center, 7 primary stroke centers, all in a large metropolitan region. They're staffed by neurologists, neurosurgeons. The radiology reads are done by neuroradiologists and also general radiologists. So I think it's a relatively real world population and representative of many practices around the country, kind of mix a little bit of everything. And these are patients that are coming in for acute stroke evaluation. So the scans are done, with the CTA stroke protocol. Those are the ones that get pushed to Viz. So the Viz algorithm had this already in their clutches. We then ran those scans through the Viz Aneurysm product, and specifically the one that's trying to look at 2 millimeter aneurysms or greater. And then we wanted to ask the question, okay, so how often is it picking up aneurysms? 1, out of the total population. 2, how frequently is it picking up aneurysms that are in fact real versus false positives? And then what happens to those patients? So if they get detected with an aneurysm, how frequently are those patients being followed up? And the ones that aren't being followed up, who are they and why weren't they followed up? And what happened to them? And that's the more kind of important question from my point of view in terms of the clinical impact of it. I will say going into this that I was, the mindset that Chris described, which is that I thought we did a pretty good job of picking up all of our aneurysms. And if there were some that were missed, they were probably small or cavernous or of relatively, minimal clinical relevance. And anything that's larger or meaningful intradurally would be identified. And then I didn't even really think about the fact that if there were a decent sized aneurysm, it wouldn't get followed up. Again, we have, I think a pretty good network of neuroscientists on our team, and was of the opinion that we were doing pretty good as a system. So needless to say, the results are very surprising to me. So just to go through the numbers again, we ran through about 1,200 CT angiograms. Of those 1,200 CT angiograms, 49 were flagged as having possible aneurysms. And as Chris said, this was all presented at the SVIN meeting a couple weeks ago in Los Angeles. That those 49 possible aneurysm scans were then evaluated by an independent neuroradiologist who had no idea what was on the clinical radiology report, and then found that of those 49, 26 of them did in fact have aneurysms. And then now we get to the kind of meat and potatoes of this study. So then of those 26, 17 of them were noted in the radiology report, but then 9 of them were not. So that was a greater proportion than I expected initially. And then of those 9 that were not in the radiology report, none of them had clinical follow-up, which we defined as some mention of it in the clinical notes during the hospital admission, or some follow-up in both our outpatient or inpatient EMRs. And then the other kind of interesting thing was even the 17 that were seen in the radiology report, the majority of them, like the vast majority of them, also didn't have any clinical follow-up. And if you look at, what were these aneurysms? Maybe they were just small, relatively benign lesions. That's not the case. Actually, the median size was over 4 millimeters. Several of them were actually quite large, and the majority of them were non-cavernous lesions. So, 85% of these aneurysms that were not seen in the radiology report didn't make it into clinical care. I didn't believe this. I'll be honest. I didn't believe this finding. So I went through each of those studies individually to see if they in fact had aneurysms and were they in fact sizable aneurysms. And it was really surprising to see, but there were a number of aneurysms that were not picked up that you would expect would have been seen. I think this is a very honest appraisal of our performance, and I would say that this is a performance that we probably see across many different health systems. I think we actually are very good, but this is, I think, reflective of the fact that we never really look to see how frequently does this happen, and when we actually look, there's a large opportunity for improvement. When we look at the rates of clinical follow-up, again, almost half of the ones that were not followed up were greater than 7 millimeters. So on the next slide, I think we have a little summary. This is that same report, just in larger font, so you can see it more clearly. But again, large percent of the aneurysms that we didn't see were of sizes that one might consider treatment, or would certainly consider additional screening and discussion with the patient. I think it's also interesting to think of this from the patient's perspective. I'm in clinic today, and there's a number of patients that I saw, and the idea of having an aneurysm can be very disturbing for a lot of patients. And even if it's a small aneurysm that is extremely unlikely to cause any problem in the patient's lifetime, that concept for many can be very difficult to handle. These are patients that want care. They really would love to be seen within the time of their diagnosis. We try to get them in as soon as possible because Many people feel this is a ticking time bomb in their brain. So a tool that can bring those results to the clinician faster and then allow us to get a hold of those patients and get them into clinic faster, get them into care faster, would one, reduce likelihood of patient loss, but it would also, I think, be great for patients who are just very naturally anxious about this diagnosis. It's a scary word. So that is a lesson that I learned. And again, I went into this relatively naively now in retrospect, thinking that most centers and most systems are performing very well in this sense. And I think we are. It's just that I think performing well means that we have this level of or this degree of patient loss to follow up. And I'll say that we did go and contact those patients that we identified to follow up with them. I think the next slide is the last one. Yeah, I think this is one of the take-home messages, which is if we don't see the aneurysm or it's not in the radiology report, it's very unlikely that that we're going to be able to follow up with that patient. And then even the ones that do make their way into the clinical notes or into the radiology reports oftentimes don't get follow-up care. And for patients nowadays, they have access to these reports, they can see these things. I had a patient today in clinic who went through one of her studies for her thyroid, and it said hepatomegaly, and she was pulling out her hair because how could they have looked at her liver when they were ultrasounding her thyroid? I think patients are very savvy about these things these days. So when you have the opportunity to, as a clinician, to get your hands on that data faster and get in contact with patients earlier, I think it leaves a lot of possibilities to alleviate their anxieties. So I think we'll pause there and turn it over to Jamie.
Dr. Sheth, thank you so much and great job on this study. I was wondering if you could just give a little bit of an overview of how this impacts your program and program growth within your center. I think you did a really good job of the impact for the patient, but what about your program impact that this tool could bring?
Yeah, it's a great question. So it's actually a fantastic question because we have a few of our hospital administrators on the call as well as we go through the attendee list. And so we have the opportunity to use this software in a research setting. We're in the process of trying to get it in the clinical setting. I think every center, every system will have to customize this for their own kind of setup individually. Because places run very differently in terms of how referrals are distributed or how patients are contacted. I think from our point of view, one is we want to make sure all these patients get attention quickly. They get in the clinic quickly and they get evaluated. And they have this discussion with one of the clinicians in a relatively expedited fashion. Looking through all those scans individually, it was very interesting to see that there were, half a dozen or maybe even more aneurysms that could potentially warrant treatment. I think that we will be uncovering more lesions that may need treatment. Again, the bar is one that's set by guidelines and clinical studies. Don't want to overreach that, but just looking through those scans without having seen the patients yet, I mean, there were a number of lesions I think would merit treatment that we would have otherwise not even known about. And again, this is to prevent subsequent rupture. So I think in terms of how it would impact us, one, being able to take care of these patients in more expeditious fashion would be wonderful. Two, I think we're going to be uncovering more lesions that genuinely deserve treatment.
Thank you. Thank you so much for that overview. I'm going to do a little bit more of an overview of additional data, but if you have questions, please place them in the chat and we'll address them at the end. So we saw the amazing evidence that came out of UT Health, and we really are focused on making sure that the AI we bring into the world, one, performs well in the real world setting. So we know that when we're doing FDA validation studies, there is that performance that happens with sensitivity and specificity and PPV, but we want to make sure that it's going to perform that same way in the real world, as well as make sure that we're understanding what the impact is for patients and for clinicians in the workflow. So we heard about the UT Health research study, but the real world performance, we had a submission at CNS that really looked at the sensitivity and specificity on 3 millimeters, and another one that's coming out at ISC that focused on 4 millimeters. And we'll give a high level overview of that data on the next slide. And an additional impact study that's coming out of a large hospital system, very similar to UT Health, large hub and spoke model, looked at how many aneurysms were found that did not have the appropriate follow-up based on the workflow of that system. So from there, you can see we have really great performance within the aneurysm study. We really looked at the validation of the algorithm performance, and this came out of UTMB, and it was led by Dr. Peter Kahn, and looked at consecutive CTAs. And we looked at 392 CTAs, and 180 of them with aneurysm and 204 without aneurysm. This abstract was accepted to JNS, and the performance really had demonstrated great performance over 4 millimeters. So sensitivity of 91%, specificity of 94%, and PPV of 88%. Dr. Sheth, can you talk a little bit about how important the sensitivity, specificity, and PPV is on a product like this from an alert fatigue perspective?
Yeah, I think it's important, but not as important as it is with LVO. I mean, LVO, it's your phone's exploding, you're waking up in the middle of the night. And, it's interesting talking to Dave go on from Viz, because my sense had always been with LVO that people would rather know than not know, and so you want higher sensitivity, even if the specificity might be lower. He had said that in user interactions, it actually had been the converse, which is that people really didn't want to have to wake up unless they knew it was an LVO. But I think in this case where it's not an urgent emergent alert, this is a population list that's being filled. We went through 1,200 CTAs and found about 50 something that were flagged. I mean, that's a relatively small proportion. It's a proportion that's consistent with the known prevalence of aneurysms in the population of around 4%. So that's very easy to flip through. So I would actually prioritize in this case for sure sensitivity over specificity.
Thank you. So really the goal of, our additional study that is done that's very similar to the design that came out of SPIN is really focusing on the same impact in different types of health systems. So looking at an academic center versus maybe a non-academic center, but a large hub and spoke stroke model, how does that change or does it change the capturing of these patients? And really the goal is to ensure that patients are captured for the most appropriate follow-up and stay within the healthcare system to be able to get the appropriate follow-up, get the clinic visit they need, get the subsequent imaging. So when we looked at an additional study that's coming out for publication, very similar, we just focused on the stroke CTAs. 20 aneurysms were detected that were true positives, which was a 55% increase in detection from what was done in the previous time frame of how many were detected, and saw an additional 75% increase in referrals. So again, they may have been detected, but never made it to the appropriate specialist for follow-up. And I think one of the things as a former hospital administrator, as I'm thinking about, needing to ensure we have program growth across the neuroscience service line, is how do we really capture patients that need care and really make sure that we're growing our programs and services for our community. So I think aneurysm has really demonstrated in both of these studies significant impact in two very different health systems, two very different population areas. So I'm going to take a stop there, and I'm going to go into the chat and see what kind of questions we have. So please enter any questions if you have any. We have a few in here. So Dr. Sheth, I think this one's for you. Of the aneurysms that were detected, what percentage were from the spoke hospitals versus the hub hospital?
Yeah, so the majority of these are all done off scans that were required for stroke patients. So the vast majority of these scans were from our CSC, from the hub hospital. That's again because the patient volume gets routed there. Again, just as an overview, these are centers that have neuroradiologists reading films, not 24/7, but reading many of these films. These are sometimes very hard to see, these aneurysms, and even when I knew that the algorithm had flagged and the independent radiologist had seen an aneurysm, it still takes a minute to scroll through and find these things. And these are scans like Chris Willie was saying are done for things other than aneurysm. So if you're not totally tuned on finding those, it's very easy to miss them.
Thank you. Chris, I think this one is for you. How quickly is the aneurysm list populated in Viz?
So the list comes out immediately. So as soon as the scan is read, it'll go to aneurysm suspected. So that's immediate. And then you would just scan through the list yourself and share to clinic. Jamie, you want me to just read through some of these? I think a few of these will be mine as well.
No, it's okay. I'll go through them. I think from that perspective of, can you talk a little bit on the product of how the notifications work and how different clinicians can set different thresholds?
So you can set threshold. We'll be able to set thresholds for what aneurysm you would want to go into your suspected list. So that is, you can do, set that up from implementation standpoint. Probably the biggest customization you can do though is your share to clinic list. And I see a question about that where when you see an aneurysm case that you want to share, you actually customize that list that you send it to. So if it's your internal clinic, great. If it's referring physicians, great. If it's a group of radiologists, great. But think of that as a self-directed distribution list that's 100% customizable. We chose share to clinic because most of the feedback we received was that the neurosurgeon or the specialist on call, whoever sees this will send it to their clinic and they'll handle it. And everyone was so different. We wanted to give them 100% control on how to set that up.
Thank you. Dr. Sheth, what percentage of the aneurysms larger than 7 millimeters were cavernous?
Yeah, so the majority were not cavernous. I think just 20% were cavernous. Yeah.
Great.
So again, many of these were lesions that as an interventionist you look at and you really start thinking about what kind of system you want to use to treat it.
Thank you. Chris, another question for you. Does the algo detect 2 millimeters or greater, 2 millimeters or greater, or 4 millimeters or greater?
That's a great question. The answer is yes. Don't confuse everybody. It detects down to 2, but to be commercially useful, we chose 4. It gets us over the sensitivity specificity hurdle that the FDA requires. But if you think about it, for us to call out a 4 millimeter, we were having internal measurements anyway to make sure that cutoff is accurate. But for commercially available product, we will detect 4 millimeters equal to 4 or larger. In the research setting, we were able to dial it down lower, which was great, but we probably won't be going too much lower than 4 just because we'll get into the world of infundibuli, et cetera, that become a little bit more tedious.
Chris, another one for you. I'm just going to read it. I'm still a college student, so this may be a stupid question, but can this AI neural network be applied to potential gliomas and other malignant growths? Well,
for a college student, you're obviously smarter than I am, and I'm a grad student, so we'll have to see where we have that. You have to text me on this one. Look, the way AI works is you train it, you show it images. Anything a human can do, we can tell AI to do it as well. For the most part, we end up being a B+ of really good providers. So every time we make an AI algorithm, we're trying to meet the standard of care that providers can validate. So AI doesn't do anything on its own. We teach it by showing what physicians can do. So physicians can do, gliomas, malignant growths for sure. There's a ton of research in the tumor space alone, mostly for tracking growth and seeing how oncolytics will work. So you could threshold it. When you deliver an oncolytic, you set an alert that the tumor is shrinking or if it's growing, et cetera. So excellent question. You're obviously on the forefront of where this is headed. So nice work.
Yes, sounds like we'll have to tune in next year for Viz glioma.
I know. Trust me, we get asked about it.
I'll make sure you leave that research study.
I know.
Dr. Sheth, another question came in. Where do you see future research going with this product? What would you like to see over time that we focus on for research?
Yeah, I think it's a broad question, but a few things that have come up are, one of the challenges that remain with aneurysm is monitoring growth, like just we were talking about with glioma. The measurements that we make are usually fairly crude, but there are very readily available tools to do volumetric measurements, but don't hit a lot of commercial taxes and then really substantial type of distribution. So if we are going to have now this model where we have most of the imaging we care about available on our phone, and we can use the same app to do volumetric measurements, look for interval changes in morphology, including size and shape, and potentially also, I'll leave this to you guys, but communicate some of these images to patients, because it's so nice to show patients images of reconstructed aneurysms, and it really is worth 1,000 words. And I'm finding myself, in clinic again, just always pulling up scans and showing patients because it's so much easier to describe, to show than to describe. So some kind of way in which we can and break down the barrier with the patient and have them more kind of engaged in this. I'd love to see those directions.
Great. Thank you. This is another question for you. What was the process to notify the patients that had the incidental findings and their next steps?
Well, so as a part of our IRB, in any study that we do, if we come across something that may need to be alerted, it could be anything. We're looking, all of a sudden we find there was a tumor, or we find something. As a part of our IRB approval, we are obligated to reach out if there's something that we think we need to address with the patient. So that's a part of any of our studies that we do.
Great. Chris, can you talk about, can you monitor aneurysm growth over time, and does it work on MRA?
So that is a great question. Dr. Sheth just kind of alluded to that. Right now we can't. We would, to monitor growth over time, the majority of aneurysms are tracked with MR, just to spare the kidneys and radiation. That's more or less standard of care. I won't say everyone does it that way. So we would need to build an algorithm that's based off MRs. That's in the pipeline to do that. And exactly what Dr. Sheth said, we would be monitoring growth. The ideal product would be retrospective, where we load all the patients that practice is monitoring, and we alert to small growths themselves. And then for sure, when you have that 3D volumetric model, you can show it to patients. And it's funny that every physician, when we start shopping this idea to, mentions like to a person that they want to be able to show the aneurysm growth to their patient in the clinic. And which is simple to us because it's just an image. That is the most appealing part of the factor. But answer is yes and yes, but it's a new version down MR, and this is based off CTAs.
Great, thank you. Chris, a little bit on subdural. Can you talk about some of the importance of measurements within the subdural?
Yeah, this is going to be, to me, the most exciting space right now. If you talk the world of subdurals, they do a simple measurement, usually a width measurement of the largest part of the bleed. Subdural bleeds are non-geometric. They tend to be very hard to quantify. So the typical formula of A plus B plus C over 2 doesn't work. For the most part, physicians will say we don't measure it because it's kind of a pain. We don't, we eyeball it. We know if it's good or bad, if the patient's symptomatic, et cetera. However, with MMA, this is such a groundbreaking treatment, and it's changing the way these patients are treated and improving, that we believe measurements are going to become very important, especially 3D volumetric measurements, which we can do. So what this means is we'll provide a width, but there will be a day, we think, now this is all speculative, but most physicians agree, where you might see a patient with a bleed and say, listen, it's at 15 mLs now. The studies have shown if we get it down to 10 mLs, arbitrary numbers, the patient will do well if they match this clinical finding. Or we burr hole down to this volume and then we MMA, after. All this data is TBD, but you have to imagine there are, 15 plus global trials going, studying this. Every big vendor with an embolic is studying this. It's the biggest pool of patients we'll see. So I think in 2 to 3 years, the volumetric in the 3D world will be so important. We don't know yet. And that's why I love this, this space right now, because for the first time, we're on the forefront of it. Usually we're catching up, but I think we're going to be able to develop this space together. And Dr. Sheth, please, if I said something wrong, or if you agree or disagree, chime in. This is more your space.
No, it's wonderful. Yeah, look forward to seeing what you guys do with this.
Great. Okay, we don't have any more questions coming in, so I'm going to go ahead and close out. We appreciate everybody for your time. We're always available, so you can message us or email us, and we'll respond to any other questions that you may have. And thank you for the groundbreaking sharing of your evidence, Dr. Sheth. We really are excited about it. And thank you for partnering with us on this study.
Great. Thanks to everyone who attended.
Yeah, thank you all.
Thank you.